Hi folks, this is John Adamson, the Rehab and Documentation Guru, standing outside my home. There's my cute dog Honey, who's outside watching our animals, right, sweetie pie, to make sure that they stay safe and we don't get any foxes eating our chickens and things like that. So anyway, I wanted to talk today about group, and there's an interesting post and other posts related to group recently. One of the posts I saw was on geriatric OT, PT, and speech collaborative group. And it's related to what's the usefulness of group, related to part Bs. I've gotten questions about, can you group part As and part Bs together, that type of thing. And so I just wanted to touch base on group as a whole. Let's define group. You probably already know, especially if you're in an inpatient setting, that group this year, as of October 1st, was changed from 2 to 4 patients to now 2 to 6 patients. And this was a way that I think Medicare was giving us the option to see more patients to help with productivity, to help improve monies coming into therapies so that they can keep therapists on staff. I don't know. But anyway, they increased the ability of therapists to see multiple patients at one time. So the first question is, how many patients should be in a group? Well, it's 2 to 6. And it really is related to what is clinically relevant. Some organizations have tried to push therapists to see at least 4 patients in a group, and that is not always appropriate. And if you are going to do group, first of all, you have to determine if it's appropriate for your patient. So whether it's a part A or part B, there are going to be patients where group is not going to be clinically effective. One of the purposes of doing group is that there's a little bit of positive peer pressure going on, for one thing, and two, it can be incentivization to patients. And again, this related to peer pressure of other people being there to encourage one another to do more, assuming that the activity is mutually beneficial to all the patients in the group. So the first thing I would say is, while we have the ability to see 2 to 6 patients in a group, it has to be relevant to the individual patients. Just sticking patients in a group because that's what you're allowed does not a group make. Secondly, is it relevant to Part B? Well, yes, group payment does occur for Part B and Part A. This is allowable. The reimbursement for a Part B patient under group is very small. Last I looked, and this might have been updated some, it was around $11 per unit. And of course, you get one group unit despite the length of time you have the patient in group. So this is not a time-based code, group therapy. So you can have a patient in a 45-minute group, all they're going to get is that one unit of care. Now, the assumption is, of course, if you have multiple patients in a group, you might get a return on your investment of time and not lose money on that time for the group. So that's one thing I would say is it certainly could be relevant, but it's going to be based on the individual patient. And going back to the principle I've talked about previously is that group is not going to be relevant for all people. So this is something that you need to be an advocate for your individual patient on. There are clearly some patients that are going to benefit from group, and so we need to stick them with their peers and encourage them to do more than they might do on the individual basis. But again, that's not going to always be the case. The other thing about group is that there really needs to be a skill behind it. And for example, I've seen some posts about groups, and I'm not lambasting therapists at all, because they're trying to come up with meaningful ways to get a bunch of people together to do the same thing or similar thing at the same time. And so I've seen, like, there was a sock decorating, grippy sock decorating group, and I thought, that's kind of neat, and perhaps there's a good skill behind that sock decorating. But one of the things we've got to ask ourselves is, why is a therapist billing Part A or Part B necessary, because of the complexity of the group, that only we could safely and effectively do the group? In other words, why couldn't you have had a activities department do that group rather than you? And a lot of the group ideas I've seen, and sometimes when I was a clinical director, a lot of the groups I saw clearly could have been done by a non-skilled entity, or activities director or restorative aid or something like that. And so we have to ask ourselves, what is the skill behind the group? Just because it's a group doesn't mean our skill goes out the window. And so we still have to hearken, nice word, in our documentation to what is the actual skilled component of that group. So while they might have been doing a sock decorating group, and again, I'm not picking on the therapist because I thought that was kind of an ingenious thing to do because it led to a safety thing and the patients got psyched about it, which is good. That solves part of the problem of a group session. You need patient buy-in. But what was the skill? And perhaps this therapist documented that. I don't know. And I'd love that therapist, if that therapist watches this video, to comment what they were focusing on from a skill component, whether it was a cognitive type activity or what. Sorry guys, I'm shivering a little bit because it's kind of chilly out here. But anyway, I'd love to see a commentary on that. But again, we want to make sure there's actual skill behind the group. Not all patients are going to need it, and you got to be an advocate for that. And if the patient can't benefit from a group, then they shouldn't be put in it, and you should be ready to back that up with clear, critical, and clinical thinking. Anyway, this is John Adamson answering several questions at one time related to group. Hope you're having a great night. God bless and take care. And bye, honey.